This is Pete Georgikakis, and we're going to be doing an update regarding cardiac arrest care, looking at some of the literature lately that is behind ACLS, or at least behind some of the treatments offered by ACLS. And then, depending on the timing, we will try and get to some community initiatives as well that we need to consider for cardiac arrest. So I have no financial disclosures. So we're going to very quickly go through the ACLS adult cardiac arrest algorithm, review the current evidence of these guidelines, and then just discuss the principles of team-based resuscitation, introduce the pit crew model that I know you know well now, and then offer some criteria about withholding and terminating resuscitation, as well as addressing some special circumstances, and then cardiac arrest at the system level. So in the United States, out of hospital cardiac arrest incidence is between 166 and 450,000 cases a year. It's most often due to ventricular fibrillation or ventricular tachycardia, but varies with time found after collapse. In hospital, the shock rhythm is up to 75%, which is not surprising because providers can get there faster to them. And then in the pre-hospital setting, that shock rhythm is much lower depending on how fast we can get to them. Overall survival, depending on the source you look at, ranges from 5 to 15%. So initially, when this was identified, prevention strategies were put in place, but those still vary. So there was public education regarding CPR training. When I was in high school, they started teaching us in the high schools. They now require coaches to know it, that kind of thing. Public access to fibrillation became a big thing in communities and has been shown to have great outcomes, as well as various revisions with the AHA and then modernization of EMS systems. But what we found overall, no matter what, is the major influencer of the outcomes is the quality of CPR during resuscitation. And that's the biggest thing that's been targeted by all interventions. So here is the cardiac arrest algorithm. Not really gonna bemoan it. It is what it is. This is what we do for everybody. So in that same flip book, as of 2010, these are just some of the key things. You know, you want to push hard and fast, make sure you're getting the right rate, the right depth, but you also want to allow full chest recoil, minimizing interruptions. And then really the advent of adding capnography was super helpful. Early on, we're looking at it to determine are the compressions of adequate quality. But then later, if it's still low after, you know, depending on your source, 20, 30 minutes, there's very poor prognosis. It also, the shock energy is based on the type of defibrillator you have. So it's important to know. Often these defibrillators will have a set manufacturer guideline, and then you might have to titrate up if it's monophasic. And then just these various other things that you know that are dictated in the protocol. But so what are the kind of the qualities of high quality continuous CPR? So there's 5 that were defined in the guidelines. Maximize chest compression fraction. So the amount of time in a code that the hands are on the chest, you want to maximize that. The compression rate, the depth, allowing full recoil, and avoiding excessive ventilation. So those are the 5 things of high quality CPR. And these are kind of the things now, you know, speaking to an EMS physician specifically, that you know, you need to be monitoring your crews are doing, and then even just as an ER attending, monitoring that these are the components of high quality CPR. Whether you have a Lucas device or not in your ED or on your agencies, you need to be able to identify high quality CPR. And if it's deficient, you need to know how to fix it in real time. Defibrillators have real-time feedback sometimes. Again, it depends on your system. And so often, you either unfortunately are looking at telemetry data after the fact, so you can do retrospective feedback, or if you're there, you can be offering, you know, as you've been doing all year in your fellowship, you can offer real-time feedback. So, you know, there's the retrospective evaluation part. So we get compression metrics, ventilation rates, rhythm management, all that. It's all extremely helpful. That's much more at the kind of global level, bird's eye view of the whole code. But when we're just talking about CPR quality, that's something that every level of provider needs to have a good handle on. So in the 2015 updates, ACLS introduced this team-based resuscitation. So they're finally getting closer and closer to understanding what is important. So you need to have the right amount of people and the correct roles. And this requires planning, practice, and positioning. So these are the roles listed. There's a team leader, someone that does access and meds. There's a timer recorder that I would argue in hospital is one of the most important people. I would say, and this might vary, and others might disagree, but out of hospital, often the monitor is keeping track of all your interventions as long as you're kind of keeping them in the machine. So you'll get one, and it will help you keep track of your timing. But in the hospital, when there's 15 people there, it's really nice to have that voice. And then you have what's called the resuscitation triangle. So you have your compressor, who's assessing for pulses, does 5 cycles of CPR, and then is alternating with the monitor person. And so then the monitor person, or if it's the AED, defibrillator, or whatever, they're the one who brings it, and they alternate with the compressor. And then you have a dedicated airway person. So this is just one system's model for where they position everybody based on the patient. And so, they have this person always on the right side who's doing the assessment and the compressions. And then we'll supply some ventilations. This is team leader. And then you have this person who's always at the head who's doing airway stuff. And then this is the other monitor person. So these two are doing the majority of the compressions. So let's look at the clinical evidence of these interventions. So compressions are only effective if they're generating a coronary perfusion pressure greater than 20 millimeters of mercury. And this requires continuous minimal interruptions because it takes some time to build this pressure up, but it takes one pause to start dumping that perfusion pressure. So that's why we care so much about minimal interruptions. And the acceptable interruption is less than 10 seconds. So anytime compression stops, I have somebody verbally start counting out loud down from 10. The problem is continuous minimal interruptions, as you know, it can be very practically difficult in EMS, especially once you get going. And that's why there's been such a push to stay on scene, because we need to maximize our high quality compressions. And we really need to be asking ourselves, what are we rushing to the hospital for? What intervention is going to be done at the hospital that we are not doing right now? And so the hands-off time is inversely associated with the arrest survival. Higher hands-off time, lower survival. The literature says that providers are maintaining the adequate chest compression fraction about 50% of the time. And even the compressions they are doing are way too shallow. And these are seasoned providers, which is pretty nerve-wracking. As we talked about, staying on scene can maximize the odds of obtaining return of spontaneous circulation because we have good evidence from all over. We did a journal club a couple years ago from Japan about how the actual quality of compressions in the back of a moving ambulance are not the same, whether it's a mechanical device or not, as on scene in a stationary position. The other thing is, by staying on scene, our compressions defibrillator are given closer to the time of the arrest. We're not having to spend time packaging. We can just be working the code. It helps to have monitors with real-time feedback. It's not necessarily a realistic expectation. Maybe in the future it will be, but I would say the on-scene EMS physician is a big way of getting real-time feedback. The data is not really the most conclusive about it being a definitive benefit, but it would be helpful to have. The ones that did say there was no benefit were in hospital arrests, and in the hospital you have a line of people out the door that are going to do compressions. So now defibrillation, it's the most effective intervention for ventricular fibrillation and pulseless VTAC. So depending on the type of defibrillator you have, it's just based on the direction of flow. And so higher shock success at lower energy levels when it's biphasic, and they found to have more ROSC. That's why everyone's been moving to biphasic. A lot of the manufacturers endorse 150, but studies show there's no impairment in cardiac function if you start higher. So like I personally shock everyone at 200. Just after talking to cardiologists during my training, that's just how my practice has developed. Some AEDs can be converted to manual monitors. This is awesome because it minimizes the delay in transitioning from a first responder AED to a full manual defibrillator, because they have found that the analyze and shock algorithm that requires you to take hands off the chest on an AED can add up to a minute of hands off time, which is a huge issue, where when you're doing with a manual defibrillator that might have some of that filtering technology that can filter out compressions, you can be doing compressions up and while it's charging up till the time of shock, and that's huge. So we need to continue to be looking at that kind of technology for our favor. So then there's this question of, when you come to an unwitnessed arrest, do we immediately defibrillate or do we need to do some compressions first? So in the past, ACLS guidelines said shock immediately if you saw VFib, regardless of how long they've been down. But the critics were saying you're shocking a heart that really hasn't been primed to get maximum benefit. So because the heart has stopped beating, there's this development of waste products, free radicals. So when you shock, the myocardium is really not ready to start repumping again. Where if you do some compressions first, you're getting rid of those waste products, you're re-priming the muscle, so when you shock it, it's really optimized for success. They did a randomized controlled trial of initial compressions versus rhythm check shock on arrival, and there was no difference. Some small studies have shown improved outcomes if the ventricular fibrillation was over 4 minutes if you did some compressions first. So what ACLS has come to now is if it's a witnessed arrest, you immediately defibrillate. If it's unwitnessed, you do 2 minutes of compressions before rhythm analysis. So as you know, the airway discussion is never ending and will not end anytime soon, and there really is no answer in sight. The big concerns mentioned are of paramedics intubating in the field is the tube could be misplaced or dislodged. It may require multiple laryngoscope efforts, multiple failed intubation efforts. You might start hyperventilating them, but the big issue is amidst all of this stuff, you can defend your paramedics' abilities left and right, but while troubleshooting all those issues, the main concern is that it's causing you to unfocus on compressions, and there becomes interruptions in compressions. So there have been a lot of studies out there at every national assembly of NAEMSP. That's one of the big highlighted discussions is you have someone that's in the supraglottic airway camp, somebody in the endotracheal intubation camp, and they just go at it and pretty much cite the same studies over and over. But the big things is it's really not a competency issue, it's a rep issue. So ACEP did a study, I think it was ACEP, that the average community ER physician does 10 intubations a year. They found the average paramedic, taking into account smallest system in the nation to largest system in the nation, about 1.2 intubations a year. But we are holding these people to the same standard. Someone that does 10 intubations a year, which still isn't that many, and someone that does less than 2. And so, when I've talked to various EMS physicians, when they talk and they do not have their crews do RSI or intubation, they say, we really frame it as this isn't a competency thing. It's not that we don't think you can do it. It's that you're not set up for success because you don't get to practice this skill enough. So it's unfair to make you, be held to this standard until we can get you more reps to know that you are in a position to accurately do this, in arguably a harder scenario, in the dark, in weird positions, that kind of thing. And we have evidence that the supraglottic airways, which are much easier to place, are equally effective. So the PART trial was a head-to-head of the King LT versus intubation. The King LT group had better 72-hour survival, ROSC, and survival with neurologic exam. The King LT also gave a 2.6-minute time advantage to definitive airway. And those that did intubate in this trial were successful ultimately about 50% of the time, which is, again, a huge issue because when they were failed, they would then start focusing on the airway and lose sight of compressions. The Airway 2 trial was IGL versus intubation. There was no difference in survival. But this actually was a little bit deceiving because it wasn't IGL versus intubation. It was essentially intubation and then a pooled group of all airway patients that were not intubated. So when you took out the group that was only bagged and never even had an airway, it truly became IGL versus intubation. The IGL did have better outcomes. And then you have systems like Harborview EMS that successfully use field intubation, but they have specific paramedic intubators that are the only paramedics that do that skill in their service and get called to the scene. And so their reps a year are going way up and they are probably meeting that standard, so they can possess that skill ability. technically the BVM is physiologically adequate. It's just practically difficult to bag someone en route and during a whole code. The literature all agrees that you need to have capnography attached. The waveform depends on quality of compressions in the first few minutes. Less than 10 means you need better compressions. Less than 10 after 20 minutes means there's a very unlikely positive outcome. It can always be used to confirm airway placement. Supraglottic airways have conflicting results, as we talked about. It really just depends on your system, your medics, and the philosophy that you have. At Johnson County EMS, we do not intubate in the field first line, with some exceptions. Because we're so close to hospitals, we do not RSI, and we have the eye gels that work for the majority of things. There's some exceptions like drowning, certain foreign body aspirations, if there's a concern that we need a tube past the vocal cords because of an issue like angioedema, anaphylaxis, that kind of thing. But at baseline, we're doing eye gels first, and it has worked very well for us. So now that you have an advanced airway in and patient is on the ventilator, recommended tidal volumes 500 to 600 cc's, respiratory rate 8 to 10. It's hard to know if bystanders who are doing CPR should also be doing ventilations. A lot of nowadays the telephone CPR algorithms are just compression only, because bystanders either aren't comfortable doing it because they don't know how, or they just are uncomfortable going mouth to mouth with a stranger. However the patient's ventilated, whenever the patient's ventilated, all studies agree that it needs to be a controlled ventilation, because if they're being ventilated too quickly, that's a problem. And they found that happens often. But you also have to make sure you're not giving too much of a tidal volume, because higher pressures open that lower esophageal sphincter and you start filling up the stomach. They can vomit. It can start messing with their breathing mechanics. And then there's been the introduction of this impedance threshold device, which is great. It generates increased negative intrathoracic pressure during recoil and increases preload and CPP, the coronary perfusion pressure. So this is what it looks like. And so essentially, the concern being when you push on the chest, air can go in, but when you let go, it doesn't create this negative space. It offloads some of that. So now the medicines. So the medications that are used in ACLS are based on tradition, theory, and animal research. The only medications involved that have had any sort of randomized controlled trials are epinephrine, amiodarone, vasopressin, and magnesium. No drug has demonstrated improved outcomes. Again, the drugs used in ACLS are not the difference maker. And I say that for a few reasons. And I would just underscore that final point as well. ACLS downplays medications in favor of quality CPR. Now, the importance of this statement is that, especially if you're out in a rural area, you're starting to run out of your epi, or you foresee that, that's okay. Epinephrine is not what is changing the outcome here. ACLS says you can give it 3 to 5 minutes. So start stretching it out to 5 minutes. That's every other rhythm check. That's okay, because the epinephrine gives you the inotropy that you need, but it is not the difference maker. So now we get to pressors. You need to understand when you initiate pressors, there's a trade-off between, is blood flow going to go to the heart or the brain? Animal data showed increased return of spontaneous circulation with early epinephrine or vasopressin. That's how it basically got introduced into ACLS. So then they looked at randomized controlled trials of vasopressin plus epi, or just epi alone, and there was no benefit of adding vasopressin. Again, there's trials that confirm you're going to get more ROSC with these meds, but no improved survival to discharge, which again is really the metric we care about. In the past, they used high dose epinephrine up to 11 milligrams. And again, these patients were getting ROSC because, goodness, you give 7 to 11 milligrams of epinephrine to a rock, it's going to have a pulse. But there was no increased survival to discharge. So does epinephrine improve outcomes? Well, it depends on how you define outcomes. Like we said, are you just trying to get a heartbeat? Then yeah, it can. If you want them surviving to discharge, okay, there's maybe a little bit of promise, but do you want them to actually have a good neurologic outcome? And that's becoming the key metric that the public has said and the scientific community has said is really what we care about. So enter the paramedic 2 trial. So I'm not going to go into a ton of this because we all know it by now, but it was essentially a randomized double-blind trial of about 8,000 patients in the United Kingdom. It involved 5 paramedic level agencies that were giving standard of care in out-of-hospital cardiac arrest. During it, they did normal protocol. However, they either gave epinephrine or saline. They were looking at survival at 30 days, and they found that epinephrine versus placebo had a significantly higher 30-day survival. Okay, so this is consistent with previous literature. The secondary outcomes, though, are really the crux of this study. So survival to discharge with good neurologic outcome with epi was about 2.2%, placebo 1.9%. Epinephrine did not significantly improve survival with good neurologic outcome. So you might have a heartbeat, but you would not have any sort of brain function. What they also found that was really interesting is the epinephrine patients, not only were they not having good neuro outcome on discharge, they had almost double the percent versus placebo of neurologic impairment at discharge. So not only do you not get a better outcome, you may actually get a worse outcome, but you have a pulse with epi. So what do we do with this? Does that mean get rid of epi? Unfortunately, not yet. There needs to be better studies that are just going to be really difficult to do. But more epinephrine patients will get ROSC, but won't have better neurologic outcomes. They might survive to discharge, but they might even venture to say have worse neurologic outcomes. But we do not have enough data yet to say that we cannot give epi. And until it is not the standard of care, we will not be able to withhold the standard of care to patients in the US at least to truly evaluate does epinephrine change outcomes. So then they decided, should we start looking at, does the epinephrine frequency matter? So ACLS is 3 to 5 minutes, which again is just based on expert opinion. So there was a study that associated dosing interval and patient outcomes. So these patients had to have had at least 2 doses of epi. And between those doses was less than 3 minutes, 3 to 4 minutes, 4 to 5 minutes, or more than 5 minutes. And then they were estimating the association of that dosing interval with survival to good neurologic outcome, which again is an outcome we care about. And so there were almost 16,000 patients. The median dose interval was 4.3 minutes, which I would think is pretty accurate. That's probably about what we do, 3 or 4 minutes. Survival with good neurologic outcome was about 4.7%. Longer dosing intervals were associated with lower survival with good neurologic outcome. Now, it's hard to know what to do with this because this article says, so that means shorter intervals between epi leads to increased survival. Now, there's a few things here because we just had another study that showed that you will get more ROSC with epinephrine. So if you're giving more epinephrine, you're going to have more ROSC. So with longer dosing intervals, you're giving less epinephrine. So they're going to say less ROSC, less survival. But then they're adding on that with good neurologic outcome. Well, if you're dead, you're dead. We have no idea to know if you would have had good neurologic outcome. So the therefore of this study is hard to know. We don't really know the pre-hospital parameters of the EMS agencies in this study. And there was a lot of bias. A lot of the patients were elderly or had gotten bystander CPR, but it's also, they weren't able to track accurately who did get bystander CPR or not. So then let's move on to antiarrhythmics. So there was this massive meta-analysis of 8 huge trials that included 4,500 patients in out-of-hospital cardiac arrest. They were looking at lidocaine, amiodarone and lidocaine, and others. And they found that lidocaine increased ROSC compared to placebo. Amiodarone and lidocaine increased survival to admission, but no antiarrhythmic was more effective for survival to discharge or neurologically intact. No antiarrhythmic was convincingly superior to any other. So here, ACLS has gone back and forth about including lidocaine or not, and now only has amiodarone, and there's no reason. We see no benefit really from either. And then they did this meta-analysis of 30 studies with 39,000 patients, and they did antiarrhythmics versus control group, versus placebo, or head-to-head antiarrhythmics. And they were looking at all kinds of outcomes like ROSC, survival, neurologic outcome. They found that amiodarone and lidocaine were the most widely used. Neither had a significant effect on any outcome versus placebo or versus each other. And then the drugs with the most benefit were not actually even used in the pre-hospital setting or in the United States. So it's hard for us to know what to do with this. There were some of these studies that had some improvement to hospital admission, which again, if you don't survive the hospital or have a brain to function, who cares? And then no effect on survival to discharge. Amiodarone remains recommended because of the arrest and the ALIVE trials. They both showed an improved survival to admission, but not discharge. They both showed that amiodarone increases ROSC, but not overall survival. We still need more research, and basically we're finding that amio or lidocaine are not harmful, but they're really not the difference maker. So now we get to bicarb. We use it all the time. We've all been guilty of going, they've been down a long time, they're probably apneic and acidotic as they retain CO2. And so we would give bicarb. They also thought early on that this might improve the efficacy of pressors and antiarrhythmics, but trials that have been done have not shown any improved survival. And they've actually found in the recovery phase in the ICU, having given a bunch of bicarb early on may be potentially harmful and alter the acid-base corrections as a patient is healing. So we do not reverse acidosis from bradypnea with bicarb. The times we give it in cardiac arrest is if it's a prolonged resuscitation with good ventilation or hyperkalemia is thought to contribute, like a dialysis or renal failure patient. We had a cardiac arrest a few days ago that was a patient that had missed dialysis, and we probably gave 6 amps of bicarb, 6 amps of calcium, D50 insulin, and we got the patient back to the ICU because this was the time for it. We knew what the bicarb was actually doing. So do we need to be changing our approach? The pit crew model, we've talked about this a bit too. 2011, Salt Lake City Fire underwent this huge restructuring to focus on high quality CPR and just more robust feedback. Crew members were given discrete tasks prior to arrival to really stick to that team-based model. And then they showed up to a pre-specified location around the patient based on their role. These were the roles: airway management, CPR delivery, monitoring, defib, meds, documentation. And then they were taken to a STEMI center where they could do PCI and targeted temperature management. So the crews were trained with didactic and video training. They also had classroom time on these updated protocols. They did a bunch of hands-on simulated resuscitations, and they were watched by the medical director, training officers. And then these changes were reemphasized every year because this study was many years. Oops. So they got feedback. The defibrillator gave them real-time feedback to minimize delay to initial defibrillation. The medical director would do post-incident reviews of all cardiac arrests, use code data for retrospective feedback. There was rhythm filtering technology, so you could see the rhythm while doing CPR. And if it was shockable, you'd be pre-charging while continuing compressions. They did selective pulse checks, which is really interesting. So you would only even check for a pulse if you saw an organized rhythm with a rate over 40, which they could see through this rhythm filtering technology, and your capnography was over 20. If there was any pause in CPR, there was an audible 10-second countdown by the compressor, and you restarted CPR unless someone said there was a pulse. They emphasized on-scene resuscitation. There was really no upper time limit, but they did encourage at least 30 minutes. But they would continue longer or transport if there were some good prognostic signs, which was CO2 over 20 with an organized rhythm, persistent or recurrent VFib. You know, the medics that work at Johnson County know that I say a patient in the field with VFib isn't dead yet. And so we really work those. Any witnessed arrest, bystander CPR, those are 2 metrics that have been found to be associated with improved survival. But then there were circumstances that led to rapid transport. And this is pediatrics, hypothermia, pregnant patients, or any scene safety concerns. And then if it was time to terminate, you could have medical control assist. They changed their ventilation habits. So to continue the focus on CPR and defibrillation, witnessed adult arrest thought to be cardiac and etiology got 6 to 8 minutes of passive ventilation. If it was unwitnessed, pediatric, or a respiratory arrest, they got 6 to 8 minutes of asynchronous BVM ventilation. And then after 6 to 8 minutes, they would get a blind King LT insertion without stopping CPR. Because again, the focus was not on airway. So these witnessed adult arrests from cardiac etiology, those are what I would call the quote unquote freshest. So the priority is not getting them oxygen. They still have the oxygen in there from when they went down. It's about priming that heart for defibrillation as fast as possible. They did find in the study that there was the introduction of the impedance threshold devices that began to be added to the advanced airway to improve negative intrathoracic pressure during the release phase of CPR so that they could truly get that air out. So before they implemented this new protocol, they had 918 arrests. They attempted to resuscitate about 36% of them, and neurologically intact survival was 8%. After the changes, they had 1,057 arrests. They attempted resuscitation in 39%, which is about the same. And they had neurologically intact survival in 16%, double the rate of neurologically intact survival. So the number needed to treat to gain another neurologically intact survivor was 12. And overall, the increase in overall function was 8%, which is huge. So the other metrics that they found were more bystander CPR and ROSC found in the field. There were more field pronouncements, which translates into less futile transports. Their survival to hospital admission trended towards improvement. It wasn't significant, but they were finding more surviving to admission. They did find an improvement in survival to discharge. Most importantly, I would say survival to discharge with good neurologic outcome improved almost double, 46% versus the 26% previously. In terms of the actual CPR delivery, there was no change in the compression fraction. The CPR rate decreased and depth increased, which is good because normally we're too shallow. And then they found an increase in the proportion of compressions within the guidelines. So their keys to success were focusing on high quality CPR, longer on-scene resuscitation, pre-assigned roles without needing prompts, improved physician oversight, which I think is huge. And my work with Johnson County has shown that you really have to be on top of every single code because every single code is unique. There are things to learn. There are styles to adopt. And then there are barriers you might identify with that bird's eye view of all the codes and putting that data together in your head. They were only transporting these patients with ROSC to STEMI centers. And then other systems that started to adopt this showed improved survival to discharge with good neuro outcome. But it was hard to know specifically what factors contributed because so many things changed. But we do know, as we'll talk about, that the BLS interventions are really what mattered. So you need to be perfecting the CPR and defibrillation in your system. So do ALS skills matter? Well, the Opal study was a multi-center controlled clinical trial in 17 cities, looked at outcomes before and after ALS interventions were introduced. And so there were 5,600 patients, about 1,400 enrolled during just the BLS phase where you were just getting hands on the chest, putting an AED on. And then about 4,200 were involved during ALS. And so the ALS skills were intubation, ACLS meds, and IV placement. They found that there was increased ROSC and survival to admission when they added ALS skills, but survival to discharge with good neurologic outcome did not change. There was no improvement in the rate of survival with the use of ALS in any subgroup. ALS skills, this study says, do not save lives. So what increased the odds of survival? So ALS interventions had an odds ratio of survival of 1, which shows no improved odds. Bystander witnessed 4 times more likely to improve survival. Bystander CPR 3.7 times. Rapid defibrillation 3.4. So the study concluded in order to save lives, healthcare planners should make CPR by citizens and rapid defibrillation responses a priority. So that's what we need to be doing in our communities. So the ALS interventions, like I said, was intubation, IV placement, and medication. They did not help neurologic survival. They actually found that the CPC scores were better in the BLS group that didn't get these meds, which is similar to the paramedic TRUE trial that says those that got epi, which would have been the medicine in this group, might be trending towards worse neurologic outcome. And then, so should we be intubating patients and giving meds? Well, it depends. I think it depends on the etiology of the arrest. I think, drowning arrests need to be intubated because it's an airway problem. But overall, it should not distract from CPR and early defibrillation. Just have to know what the cause of the arrest is. So we're just going to talk about medical codes quickly. Withholding, so coming on scene and not starting resuscitation. The big thing is just your agency has to have a policy. And so I pulled this from ours that I wrote. And so they have to have, the big indications. They're clearly dead, decapitated, decomposing, transected of the torso, incinerated, some sort of injury incompatible with life. It had to be non-traumatic with obvious signs of death. So lividity and rigor, you need to make sure your providers know what those look like because it's not a guarantee that your first responders will. We've had multiple times where Johnson County goes to cases where a patient is got dependent lividity that just wasn't noted or recognized by first responders. Excuse me. If the patient has a valid DNR order or actionable I-post, obviously you don't need to start CPR if it says do not resuscitate. And so the key here is actionable I-post. So you need to make sure it's filled out correctly, it's signed in the right places, otherwise it is a void document. And then there also should be somewhere, you know, in your policy, some sort of gray area for the on-scene medic to decide. And so ours is just futile as determined by agency. And so this is kind of this last line is from the NASEMSO guidelines that you need to have something. So I've further delineated what our agency guidelines are, which is the submersion one is kind of in its own thing, but limited resources, dangerous scene, and any sort of concern from the provider for safety, then we're not going to stay on scene and try and resuscitate someone if the provider's life is in danger. So just some quick definitions. An advance directive is written by the patient who has capacity expressing future wishes for different scenarios, and they might name a decision maker. So a living will is a theoretical document. It is not usually helpful for EMS. Durable power of attorney is who the surrogate decision maker will be. If the patient is conscious and has capacity and their surrogate is there, they're not activated yet, so you can still talk to the person with capacity. A DNR is written by a healthcare provider that states when a patient is pulseless and apneic, do not resuscitate them. So an advance directive can be all kinds of things, but the patient decides in this scenario, in this scenario, in this scenario, these are the things I do or don't want. DNR is basically an order by a healthcare professional that when they are pulseless and apneic, you do nothing. It might be further delineated into just do not intubate or what. And then an I-post is written by a healthcare provider with explicit guidance with acceptable interventions in the form of medical orders. And again, this is actionable when it's signed and filled out correctly and often tells you what to do if they're pulseless and apneic. So this is, you know, if they meet the criteria, you do not start CPR. If it has been started by someone else, but you get there on arrival and these criteria are confirmed, you can stop. You can always call online medical control as needed. If you're in doubt, I would start and contact medical control. This is what I tell the paramedics. If there is a patient or surrogate with documentation that they want to revoke the DNR and want you to do everything, you should abide by those wishes. They have to have documentation, because how many times have we gone on scene and a spouse is not ready to let go of their loved one and says, no, they want everything done, but you're holding a DNR order. That's different. If they are the documented decision maker, they can tell you that. But if it's just upset family, unfortunately, you just have to kind of talk them through it, calm them down, help them understand the process. Also remember that there's other tasks. You know, we need to set up, make sure law enforcement will be able to secure the scene, waiting for the medical examiner, emotional support, keeping them updated. I know, and we'll get to this with termination, but there's sometimes some concern about a family being super upset about terminating. But, you know, the studies have found that just keeping them updated through the call, through the code, the parameters you've done, the decisions you're making, why you're making those decisions, the families are actually remarkably understanding. If there is a valid DNR order, but they have signs of life, still treat them. They're not dead. DNR means when they're pulseless apneic, do not resuscitate them. It doesn't mean don't keep them comfortable. Like we said, the I-post will have specific guidelines. They might say what kinds of interventions they do or don't want. So just follow your protocols and defer the things that their I-post says to not do. If they are actively dying or meet criteria to withhold, continue to provide care, but just keep them comfortable. And that might include pain meds, fluids, respiratory care. Comfort care only does not mean do not treat. And sometimes family members don't know that. They will push you back and say, no, she's a DNR or she's comfort cares, but she's alive. So continue to treat the patient. Termination. So you need to have a policy. The goal of termination is not to have more deaths, it's to prevent futile transports. The Verbeek-Morrison rules were initially developed so that BLS providers could stop transporting patients with extremely poor prognoses, and they've been validated multiple times. So if it's an unwitnessed arrest by EMS with 3 cycles of CPR done, 3 no shock advised on AED, and no return of spontaneous circulation, these study rules say that the BLS providers can terminate. They have since validated these criteria for ALS services. So unwitnessed by EMS, full ALS resuscitation has been done, which is airway access meds. They've remained in a non-shockable rhythm for at least 20 minutes. You haven't started transporting. They were never shocked, never achieved ROSC. You can terminate. Now, the thing here is, and we talked about this a little bit, but the next question being, so if the patient is shocked early on, since now they don't meet the termination criteria, do we have to start packaging up and go? And I would say the answer to that is no. I think, as I said before, the answer you have to continually be looking for is, if I take this patient to the hospital right now, what are they going to do? Did that shock, especially if it did not get ROSC, if that shock continues the code, why do I need to package them up? What am I still heading to? If they're a hypothermic patient, if they're a trauma, if they're a overdose, and you know what the hospital is going to be able to do that you can't, okay. But if this is just a patient that received an incidental shock with no ROSC, and you're continuing through these guidelines, while they're not the set TOR personnel, you still don't need to suddenly, the flip is not true. You can meet the TOR criteria, and then you're not transported. If you don't meet the TOR criteria, that doesn't mean you have to be transported. And I think that sometimes is a difficult distinction. So I think the way you phrase it to the medics, which is what I do, is continue to ask yourself, if I package them up, shock or not, what am I taking them into the hospital to be accomplished? And that brings us to our exclusion criteria. And I use these a lot in our protocol, because this really protects your medics in that it gives them those scenarios where they might benefit from some sort of intervention at the hospital. So your trauma arrests, that's kind of its own thing. Talk about that at a different time. Lightning strikes, drownings, pregnancy, hypothermia, overdose, and pediatrics. So we'll talk about lightning strikes and drowning. Pregnancy, need to get to the hospital because there are various interventions that can be done to both mom and fetus. Hypothermia, there are options, including ECMO. Overdoses often have antidotes that we can treat. And there are no good prognostic factors in pediatric arrests, such that I do not burden field teams from having to call pediatric codes. They transport them all unless there's an obvious sign of death. As we talked about, you concerned about the family? Well, studies show that proper counseling and explanation improve relations. So that universal prediction rule we talked about has a positive predictive value of 99.5% of death. Patients that meet all those criteria have less than 1% chance of surviving, so there's no reason to transport. You're also going to catch 90% of those that would survive. So the point is just you're decreasing fetal transports and decreasing taking people to the hospital that are not going to discharge with good neurologic outcome. We've talked about how capnography can weigh in. Also consider your logistical factors. Even if a patient meets termination of resuscitation, are you on the interstate with a bunch of cameras around, that kind of thing? It's probably worth continuing in private to the hospital. There are scene factors that could be unstable, it could be unsafe, might be very public, it might be very emotional. There are times that are non-medical that it's worth getting off the scene and just taking the onus off your EMS crews to make this decision and allow the hospital to make this decision. This is important for you to know because there's always questions on EMS boards about the universal termination of resuscitation. So just because I wanted to get to this, in case we don't have time to talk about lightning strikes and drowning, I just want to talk about systems of care. This is something that'll be really important for EMS physicians that are dealing more at kind of regional leadership level. So as we talked about, arrest survival is based on the interval from collapse to CPR defibrillation. So there started to be this push towards increasing efforts to faster response. So we trained firefighters and law enforcement in CPR and defibrillation. We trained EMTs to start using AEDs and defibrillators. And we started this SSM system of deploying ALS units in real time based on where the need was greatest. We got AEDs in areas of high risk and high density of population to make sure early defibrillation was happening. And we started to highlight the importance in publicly educating people on the immediate bystander action and how important it is. Areas that have bystander CPR and AED use have survival up to 50% compared to the 5 to 15% of other areas. We need to educate the public that they are vital to survival. EMS and hospital staff have less impact on survival than bystander CPR and AED. Studies all agree. So keys to community cardiac arrest care: early recognition, calling for help. This requires educating the public on how to recognize. 911 dispatching: you have to make sure your EMD is good and that there is good pre-arrival instructions and an adequate telephone CPR system. Ensure that you have bystanders doing CPR and trained in it. Public access to fibrillation, good BLS care. That's the key no matter what kind of agencies you're working with. It has to be fundamentally CPR and defibrillation has got to be key. Then good ALS care, good post-arrest care, and then you have to have in your region a good registry and QI system to ensure that the system is working. So educate the public on the awareness of out-of-hospital cardiac arrest, recognition, importance. Laypersons do not reliably check pulses. That's why ACLS has taken checking a carotid pulse out of it before starting compressions. If you're unresponsive, not moving, and not apparently breathing, laypersons are now instructed to start compressions. Your emergency medicine dispatchers need to quickly identify patients that need CPR instructions. The most often reason cardiac arrests are missed over the phone is because of some sort of description of funny breathing. So these pre-arrival instructions are vital. Only 5 to 10% of centers provide completely correct pre-arrival instructions, and this is why your dispatch centers have to have a robust QA system. Dispatcher instructions for CPR improves likelihood that the caller will perform CPR. If you don't tell them to do it, they're not going to think to do it. Dispatcher life support is a class and a certification that provides skills and procedures used by EMD to provide care. It teaches them how to talk laypersons through it. Also know how your local dispatch area operates. Is this a true validated EMD versus homegrown protocols? Because that is very significant. Bystander CPR, all studies agree it improves survival benefit. It has survival benefit if you have bystander CPR. You need to be monitoring and optimizing the rate of bystander CPR in your area. Regular public education sessions and hands-on practice. Encourage frequent switching. Laypersons who don't do this a lot do not realize how tired they're getting. And they actually changed ACLS a long time ago to make it these multiple cycles before a pulse check. Also to ensure that there is adequate breaks so that people can be switching, because they were finding people were getting to exhaustion, and then because they hadn't switched, there was this delay in switching compressors before. So there would be this long delay in compressions. It is acceptable to have compression-only CPR. The point is that somebody is pushing on the chest to keep blood flow going, keep the heart primed. Public access to fibrillation. 70 to 80% of VFib can be successfully converted if shocked within 3 minutes. That survival decreases up to 10% every minute that passes after. Modern AEDs don't allow an inappropriate shock. There's many available. There's even one specific for laypersons. Some can give telemetry data, feedback devices. So it's just important to know what your area would most benefit from. There's great evidence in the efficacy of early AED use in both first responders and bystanders. High-risk locations must be identified. You need to work with your dispatch center to know where would be the best places for this: stadiums, malls, movie theaters, churches, that kind of thing. They're really encouraged to register these with dispatch centers, develop a notification system for responders, training, deployment. Got to be maximizing our BLS care. The Opal study showed us that time to defibrillation by BLS is all that mattered. And so their goal was, and a subset of this Opal study is they had a goal of defibrillator-equipped vehicle on scene within 8 minutes of a 911 call, over 90% of the time. When they, as their proportion of calls increased that met that standard, they had increased survival to hospital discharge. So the faster an AED is put on a patient, the faster the better they do. So ensure high quality continuous chest compressions, whether it's through training, do they have mechanical devices that are being used, understanding that they still need to know how to do it because there are still many patients that will not fit a Lucas device. And then you just want to make sure you are anticipating that your compressors are going to get tired. And even if they're not thinking about it, you need to be thinking about, okay, who is going to be giving them breaks? The Opal study shows ALS care does not routinely improve survival, but there was a massive European Council review of all the literature. There was no specific airway approach that they seemed to support. They were considering BVM versus supraglottic versus intubation. There was really no optimal timing for this airway, but they did say you had to have capnography. The airway is controversial. We still don't really know. You really just have to think about your providers, their reps, your system, that kind of thing, and what kind of oversight and training will be required to implement whatever you decide. Post-arrest care is huge. It's kind of its own lecture, but the majority of morbidity and mortality after cardiac arrest is due to cerebral and cardiac dysfunction. Neuro recovery influenced most by post-arrest care. There's not really standardized post-arrest care at every facility, and they blame a variety of things. But should we be regionalizing our care? Should we just be sending ROSC patients to centers equipped with guideline-based therapy? They could be doing targeted temperature management, PCI 24/7, ECMO. So there's talk about that. But the big thing is that you need to have a protocol for ROSC so that every single time your medics know that that's what they need to do. And then you have to have a cardiac arrest registry with QI. This will collect performance and quality data to improve treatment. You want to monitor things like treatment time intervals, CPR performance, and use that Utstein template. Also be aware of national registries to look at as models, and you can compare your agency to national averages as benchmarks. This will help monitor performance in areas you need to improve. Finally, kind of a good thing to think about is you want to place EMS and resources in areas of the most arrests, and this will be based on geographic mapping, dispatch center, demographic criteria. You know, there's some agencies like area ambulance that use SSM, so just this roaming ALS based on the real-time needs. Then there's concern though, is there skill dilution? You know, I was just in the hot area, then got a call, so I left. So now another crew is going to get that versus when I'm stationed, I will get all the big things in that area when I'm around. But, you know, with dynamic movements, I may not be back in that same spot again once I'm cleared from the call. So there's different pros and cons to each. Tiered response is an interesting thought too, because we know that the BLS care is all that matters. Should we be using first responders as well? Should we be using them at all? It kind of all depends. If you're going to have a tiered response, you have to have an objective, systematic EMD for sure. So just for the sake of time, I'm going to probably defer these three special circumstances because there's a lot to be said about each of these. But I think the important thing is just understanding the literature behind ACLS and understanding what the literature actually says, what kind of changes true outcomes, and then understanding at the system level what kind of things need to be on your mind as you become a community leader and as you're training new paramedics. So I hope this was helpful. If there's any questions, please email me. Otherwise, have a good day.